Hi there, welcome back to Chapter 17, Neurological Emergencies, Chapter 18 in the 12th edition of our Emergency Care and Transportation of the Sick and Injured. Stroke is the fifth leading cause of death and the leading cause of adult disability in the United States. It's very common in geriatric patients. There are several contributing factors to stroke that include family history and race, but there are also a variety of treatments that are available for stroke, and there are improving treatments available for stroke, and they continue to get better over time. Many hospitals are certified as stroke centers. Rapid transportation is vital, and those hospitals that are not stroke centers actually do have protocol related to responding to stroke and getting resources to the smaller hospital environment. Seizures and altered mental status may also occur. Seizures are a very common call for paramedics, for ambulance, for EMTs, and it can be the cause of a recent or a prior head injury, a brain tumor, a metabolic problem. Very commonly, it's a product of a fever or a genetic disposition. And then the patient experiences a seizure, and it is very common for them to have a history of seizures and possibly be taking some medication for a seizure. Possible causes of altered mental status include intoxication, head injury, hypoxia, stroke, metabolic disturbances, and treatments vary widely and are based primarily on the pathophysiology behind the altered mental status. Remember in anatomy and physiology that the brain is the body's computer. It controls breathing, speech, and all body functions. There are three parts: the brainstem, the cerebellum, and the cerebrum. The cerebrum, of course, is the largest part, and that's our thinking brain. The remaining part of the brain, the brainstem and the cerebellum, do all of the automatic functions that our body needs in order to survive. The brainstem, most importantly, controls breathing, blood pressure, swallowing, pupil constriction. The cerebellum controls muscle and body coordination, including walking, riding, picking up a coin, playing the piano, understanding complex tasks. Where the cerebrum is divided into right and left hemispheres, each controls activities on the opposite side of the body. So the right brain controls the activities on the left side of the body. The front of the cerebrum controls emotion and thought. The middle controls sensation and movement, and the back processes sight. And when we're talking about strokes, and that can occur at any part of the brain, if, for example, it affected the front of the cerebrum, you may not have that, um, right or left side stroke. You might not have that finding, but what you have is that the patient's emotions or thoughts are disrupted, or they're not able to control them, or they become unemotional, or stop thinking about things. And that could be the potential outcome from a stroke in the front of the brain. Same goes for the middle. Sensation and movement may be altered. Or for the rear side of the brain, where sight is interpreted, and that may be affected, and the patient may complain of sight changes or not understand what they're looking at or what they're seeing with their eyes. In most people, speech is controlled on the left side of the brain near the middle of the cerebrum. Messages sent to and from the brain travel through nerves. Now, there's 12 cranial nerves specifically that run directly from the brain to parts of the head, and these are a very sensory component. So, and also motor component, but functionally they run the senses for us and those organs that are associated with our senses. So the eyes, the ears, the nose, and the face. So these 12 pair of cranial nerves that you do not have to memorize, but you should be aware of, are olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. So these are 12 cranial nerves that they actually look for in concussion patients and also in dive emergencies. They're looking to see, they will do an assessment that basically assesses all 12 of these cranial nerves. And in doing that assessment, if one of them were not reacting appropriately or accordingly, then they would be sure to do further investigation, perhaps a CT scan, to see if there's any brain damage. The rest of the nerves join in the spinal cord, and they exit through the brain through that large opening called the foramen magnum, meaning magnum large, foramen whole, right? That's basically it. That's the only way out of the brain. So, unfortunately, if somebody has brain swelling, that's the path of least resistance, and the brain will actually start to push through the foramen magnum as well. At each vertebra in the back and the neck, two nerves branch out, the spinal nerves, and these carry signals to and from the body. Signals that are carried away from the brain are the motor nerves, so the brain is telling the body to go do something, and the nerves that are bringing information back to the brain, those are our sensory nerves, and they're telling the brain this is what they're feeling. So, again, just an image of the brain and spinal cord, aka our nervous system. Many different disorders can cause brain dysfunction. They affect the patient's level of consciousness, speech, and voluntary muscle control. The brain is sensitive to changes in oxygen, glucose, and temperature. Any variation in those three components will affect the brain and will cause some type of altered mental status. So the brain gets too cold or too hot, it's going to start shutting down. If it doesn't get enough oxygen, it'll start to show that it is not working properly. If it doesn't have enough glucose, the brain will die. If a problem is caused primarily by disorders in the heart and lungs, the entire brain is affected. If the primary problem is in the brain, the only part of the brain that is affected, until there becomes other problems associated with that initial injury. For example, somebody has a stroke, and that stroke leaks blood into the brain tissue, which is very necrotic and destroys other brain tissue. And then the swelling that occurs after that may create more damage to the rest of the brain because there is only so much space, and the larger or the more swelling that occurs in the brain, the more impact it will have on the rest of the brain. So those secondary components can also be a problem caused by the primary problem. Headache is probably one of the most common complaints we'll get for a variety of reasons, whether it's trauma related, allergy related, migraine related, cold related, influenza related. Headache is super common. It can be a symptom of another condition or a neurological condition all on its own, and only a very small percentage of headaches are actually caused by a serious medical condition. Tension headaches, migraines, and sinus headaches are the most common, and these are not considered life-threatening. Sinus headaches can evolve into a serious bacterial infection that can cause sepsis. Other problems can be associated with that, bacterial sinus infections, but sinus headaches by themselves are not life-threatening. Migraines can be so severe that they feel life-threatening, but again, also not life-threatening. Tension headaches are caused by muscle contractions in the head and neck. Most of the pain is usually described as squeezing, dull, or as an ache. It can be stress related, felt around the shoulders and up towards the back of the head in the occiput. Usually does not require medical attention, although people do call for medical assistance when they experience a tension headache. Migraine headaches are thought to be caused by changes in blood vessel size at the base of the brain. They're experienced by both adults and children. Usually, the pain is described as pounding, throbbing, or pulsating. It is also often associated with nausea and vomiting and can be preceded by some oral visual changes. It can last for several hours or days. Additionally, patients may complain of some photophobia, just that it hurts more whenever they're in light areas. They prefer a nice, calm, dark, cool environment to rest in. Sinus headaches are caused by pressure that is the result of fluid accumulation in the sinus cavities. They may also have cold-like symptoms, nasal congestion, cough, fever, allergies. Pre-hospital emergency care is not typically required. Serious conditions that include a headache as a symptom are hemorrhagic stroke, brain tumors, and meningitis. So if the patient complains of a sudden onset severe headache or a sudden headache that has associated symptoms like nausea, vomiting, and photophobia, or suspect stroke in patients with a severe headache, seizures, and an altered mental status, increasing intracranial pressure, that's ICP, may be caused by hemorrhagic stroke, tumor, or recent head trauma. Now remember, we talked about head trauma previously and the increasing intracranial pressure and what that causes as far as blood pressures and pulses. A CVA is a cerebral vascular accident, which we also call a stroke. It is an interruption of blood flow to an area within the brain. A stroke can be caused by several different components. It can be because something broke off in the bloodstream at a distant location and has now ended up in the brain. It could be because of that atherosclerosis, that buildup of the plaquiness inside the brain. It could also be a result of an aneurysm within the brain that is often caused by arteriosclerosis, or hardening of the arteries that weakens that inside of the arterial vessel and then allows it to bubble up and eventually rupture. Any interruption of blood flow to an area within the brain will result in some type of reaction, and depending on where it lands in the brain will depend on what that reaction is. And depending on how much brain tissue it's also affecting. Lacking oxygen, brain cells will stop functioning and begin to die within minutes. And once the brain cells actually die, not much can be done to recover them. The brain, however, is a miraculous organ, and when there is an impact to part of the brain, the rest of the brain will attempt to pick up where it left off. It will try to coordinate some of those other functions that the body needs. Brain cells develop ischemia, causing them to stop functioning properly. It can take several hours or more for cell death to occur. With prompt restoration of blood flow, the cells will not die and function can be preserved or restored. There are two main types of stroke. There are ischemic and hemorrhagic. Ischemic is related to that thrombus and or embolus, and the hemorrhagic is related to an aneurysm. Ischemic strokes are most common, accounting for more than 80% of all strokes. They result from a thrombosis or an embolus, so that atherosclerosis or an embolus from another location. Symptoms can range from nothing at all, barely noticeable, to complete paralysis. Atherosclerosis in the blood vessels is often the cause, most often. Atherosclerosis, plaque forms inside the walls of the blood vessel and can obstruct the blood flow, and eventually it will cause complete occlusion of an artery. Hemorrhagic stroke accounts for about 13% of all strokes. That results from bleeding inside the brain. Cerebral hemorrhages are often fatal, unfortunately. When they do rupture, they cause increased damage to the tissue that surrounds the rupture. And unfortunately, blood is very necrotic for brain tissue, so brain tissue tends to break down very quickly with frank blood within that area. People at high risk include those experiencing stress or exertion, and people at highest risk are those who have very high, especially uncontrolled blood pressure. Here's an example of an aneurysm. There's a swelling or enlargement of the wall of an artery, resulting in the defect or weakening of the arterial wall itself. In hemorrhagic stroke, symptoms are often sudden onset with a severe headache. When a hemorrhagic stroke occurs in an otherwise healthy young person, it is likely caused by a berry aneurysm, which is actually something that is a congenital defect in when the brain was being put together in the fetus. Then there was a mix-up of the vessels together, which created weaknesses in the walls that creates this berry aneurysm. Surgical repair may be possible. It depends on what area it's located in and if there's actually been rupture of blood into the tissue. When blood flow in the brain is obstructed due to atherosclerosis or a small blood clot, the patient may exhibit signs of stroke. But when these stroke-like symptoms go away on their own in less than 24 hours, the event is called a TIA, or a transient ischemic attack. They actually consider TIAs to be strokes now. They don't just refer to them as a potential for a stroke, but they actually don't have any death or tissue, and they are actually a precursor to a major stroke. So they consider TIAs to be strokes now, but they are precursors to a major stroke. Symptoms of a TIA can last up to 24 hours or as little as a few minutes. You're not able to differentiate between a stroke and a TIA unless the symptoms resolve, which does happen. So you might respond to a patient who's complaining of stroke-like symptoms, and you get there, and they do, sure enough, present with stroke-like symptoms as you're doing your assessment. Then the patient suddenly becomes coherent. They're able to use everything like they were before. They begin to act normal, and that is then evidence of a TIA. It's really important that you advocate for the patient, you demonstrate and document to the emergency care receiving physicians exactly what you saw, and that they understand that the patient was experiencing very clear stroke symptoms and that they resolved prior to your arrival. There is a really good video I'll share with you in class, and this video demonstrates somebody who had been to the emergency room in the UK a couple of times, and they did not get any treatment. They did not believe that they were having any stroke-like symptoms, and were not treating them as if they had a TIA until they actually caught it on video. And it's a really good video, a good demonstration of a TIA. It's often a warning sign that a more significant stroke is going to occur. All patients with TIA should be evaluated by a physician. When we're assessing a stroke patient, we're looking for any facial drooping, any sudden weakness or numbness on the face, arm, leg, or one side of the body, decreased or absent movement and sensation on one side of the body, lack of muscle coordination, or loss of balance. Signs and symptoms of stroke can include sudden vision loss in one eye, blurred and double vision, difficulty swallowing, decreased level of responsiveness, and also speech disorders. Aphasia, difficulty expressing thoughts or the inability to use the right words. Expressive aphasia, difficulty understanding spoken words. That's receptive aphasia. Slurred speech, dysarthria, sudden and severe headache, confusion, and dizziness. Weakness, combativeness, restlessness, tongue deviation, and coma are also all signs and symptoms of stroke. In a left hemisphere stroke, the stroke is in the left cerebral hemisphere. It can cause aphasia, because remember, that's where a lot of our speech is generated from. Inability to produce or understand speech. Speech problems will vary widely. Stroke can also cause paralysis of the right side of the body in a left hemisphere stroke. A right hemisphere stroke may cause paralysis on the left side of the body. Usually patients can understand language and are able to speak. The words may be slurred. Patients may be oblivious to their problem. Neglect and lack of pain cause many patients to delay seeking help. When we're dealing with bleeding in the brain, patients often have high blood pressure, and that may be the cause of the bleeding, or it can be caused by the bleeding as a compensatory response. Increasing intracranial pressure will increase the blood pressure. Significant drops in blood pressure may occur as the patient's conditions worsen. Monitor the blood pressure for changes every 5 minutes for your critical patient. Conditions that can mimic stroke include hypoglycemia, i.e., not enough blood glucose. And when we talk about diabetes and endocrine disorders, we'll talk a lot about hypoglycemia. Postictal state: a patient may have a seizure that lasts between 5 and 30 minutes, and they may have this postictal period where they're generally not responsive, a little bit tired, incomprehensible in speech, and they don't necessarily follow motor commands. It's characterized by labored respirations and some degree of altered mental status. And of course, subdural and epidural bleeding, which are common in elderly patients, even at ground level falls. Blood near the skull presses on the brain, and it affects the brain, so it begins to present stroke-like symptoms. These are just images of subdural hematomas in different locations. A neurological episode caused by a surge of electrical activity in the brain is what causes a seizure. It could take the form of a convulsion, or it can be associated with temporary alteration in consciousness. The patient just doesn't respond to anything in their environment around them. There are generalized and partial, or in parentheses, you'll see that focal seizures. Generalized seizures result from abnormal electrical discharges on a large area of the brain, usually unconsciousness and tonic-clonic type twitching all over the body for all of the muscles. Those are the motor nerves that are sending crazy signals because the brain is going through a crazy electrical movement. It's maybe simply characterized by a brief lapse of consciousness. So maybe the patient doesn't have any motor activity at all. They just are not responsive for a period of time. In partial seizures, there's no change in the patient's level of consciousness, but they may have numbness, weakness, dizziness, visual changes, or unusual smells and taste. Some can have some twitching or brief paralysis. Complex partial seizures include altered mental status. It results from abnormal discharges in the specific area of the temporal lobe in the brain, lip smacking, eye blinking, and isolated jerking, unpleasant smells, visual hallucinations, uncontrollable fear, and repetitive physical behavior. An aura is something that patients who have seizures experience prior to a seizure. It includes maybe visual changes, hallucinations, discoloration in the periphery of their gaze. People with a history of seizures recognize their aura and usually will try to take steps to minimize the injury if they do recognize it. Auroras do not occur prior to every seizure, and not all patients with a seizure disorder experience an aura. Generalized seizure are characterized by sudden loss of consciousness, chaotic muscle movement and tone, and apnea, so they stop breathing. They exhibit bilateral muscle movement characterized by a cycle of muscle rigidity and relaxation, usually lasting 1 to 3 minutes. Tachycardia, hyperventilation, sweating, and intense salivation occur. Most seizures last between 3 to 5 minutes, and the postictal state that follows is about 5 to 20 minutes long. Then there is a gradual return to consciousness. Absent seizures, formerly called petit mals, may last for seconds. The patient will fully recover with a brief lapse of memory. Usually not any tonic-clonic activity in that type of a patient. Now, status epilepticus is a seizure lasting more than 5 minutes, potentially will progress to status epilepticus. But seizures that continue every few minutes without regaining consciousness or last longer than 30 minutes are referred to as status epilepticus. So there is a change in that from previous lessons in seizures, in seizure activity in years past. So there is now seizures that continue. It's important to remember this: seizures that continue every few minutes without the person regaining consciousness or last longer than 30 minutes are referred to as status epilepticus. And that is a critical life-threatening emergency. They do need medications to stop the seizures. They need to be transported as soon as possible. That first line seizures lasting more than 5 minutes are likely to progress to status epilepticus. It's important to remember that in the past, if a patient had a seizure for 5 minutes, they were automatically status epilepticus, but that has changed. They are no longer considered absolutely status epilepticus if they continue for 5 minutes. However, if it does last more than that, they're very likely heading in that direction, according to the new knowledge. Some seizure disorders are congenital, others can be caused by high fever, structural problems in the brain, or metabolic or chemical problems. Epileptic, it's not that uncommon of a disorder. Seizures are actually kind of common. We pretty much just want to protect them and make sure that they don't hit anything whenever they fall to the ground and that they're not hitting anything while they're having a seizure. Allow them to go through the seizure process and then to go into the postictal state, provide comfort, and then have them go home to rest. Or typically they are not necessarily transported to the hospital any longer, nor do they require it if this is a part of the history. If they're taking medications and they're having more frequent seizures, then it's certainly something that the doctor is going to want to see them for, to see if they can figure out why the patient is starting to have seizures again while they're on their medication. Additionally, fevers are a very common cause of child seizures, of infant seizures, and those fevers can be pretty scary. They're usually pretty high, like 104 degrees whenever they have a seizure. And for parents with a perfectly healthy child now experiencing a seizure, that's an extremely scary situation. All children, their first seizure especially, should always be evaluated in the emergency room. We cannot say, yeah, definitely, it's just caused by a fever. We can make that interpretation that it may have been caused by the fever, but ultimately, all first seizures should always be evaluated in the emergency room. All first seizures for children, especially. Epileptic seizures can be controlled with lots of different medications. One of my favorites is phenobarbital, only because of the way that patients like to call it peanut butter balls. Seizures can be caused by an abnormal area in the brain, like a benign or cancerous tumor, an infection, or scar tissue from some other type of surgery. Seizures from a metabolic reason can be caused by abnormal levels of certain blood chemicals, hypoglycemia, that's low blood sugar, poisons, drug overdoses, sudden withdrawal from routine heavy alcohol or sedative drug use, sudden withdrawal from medications that they're taking for a number of reasons can also cause onset seizures. Prescribed medications and seizures can also result from sudden high fevers, particularly in children. Recognizing when a seizure is occurring and whether this episode differs from previous ones is important. Patients may turn cyanotic. Seizures may prevent the patient from breathing normally. It also may place the patient in a position that, for example, if they were swimming in the pool or in a lake and they have a seizure at an unfortunate time, then not only are they at risk of having the seizure, but they're also at risk of drowning. In a patient with diabetes, blood glucose levels may decrease if they did not have low blood glucose beforehand. The increased intensity of the muscle activity will definitely use up more glucose stores. If the protocol allows in your area, make sure to monitor blood glucose levels after a patient with diabetes has a seizure. Try to look at other problems associated with seizures. Patients who have fallen during a seizure may also have a head injury now. It's not uncommon for them to have some oral trauma, whether it's biting their tongue or knocking out their teeth. Patients having a generalized seizure may also experience incontinence. It's actually very common for them to leak urine whenever they have a seizure. After a seizure, the muscles relax, becoming almost flaccid, and breathing becomes labored because they're making up for that lack of oxygen because they weren't breathing during the time of the seizure. The breathing pattern helps the body balance the acidity in the bloodstream. With normal circulation and liver function, the patient will begin to breathe more normally within minutes in this postictal state. Sometimes the postictal state can be characterized by hemiparesis, resembling a stroke, so one-sided paralysis or one-sided lack of sensation. Usually it is characterized by lethargy and confusion. Patients can be combative, especially if they are a regular seizure patient and they don't want to be transported, they don't want to be treated, and they certainly don't want all of the attention that they're receiving. Be prepared for these types of circumstances. The patient's condition doesn't improve, consider hypoglycemia or infection. Also consider that the patient may go into another seizure, and then at that point they should be transported. Seizures are often mistaken for syncope or fainting. So syncope is the fancy word for fainting. Fainting typically occurs while the patient is standing. Seizures may occur in any position. Fainting is not associated with the postictal state. So if somebody faints or has a syncopal episode, they should not have a postictal episode coming out of that. Altered mental status, aside from stroke and seizures, is probably the most common neurological emergency that we face. There are so many causes to altered mental status. And this is where being the investigator comes in handy, asking a lot of questions, trying to dive down to the root of the problem. What could be causing this altered mental status? Basically, the patient's not thinking clearly or is incapable of being awoken or aroused. And in some cases, the patient will be unconscious. In others, the patient may be alert but confused, not able to answer those who, what, when, where, why questions. Hypoglycemia, signs and symptoms that mimic stroke or seizures, may have some one-sided paralysis or one-sided lack of sensation. Patient who has had a stroke may be alert and attempting to communicate. A patient with hypoglycemia almost always has an altered or decreased level of consciousness, and they can also experience a seizure. In hypoglycemia, patients commonly take medications that lower their blood glucose level. Important to know is what the last meal the patient had, the last time they took their blood glucose lowering medication, and also what their last blood sugars were and when that was taken. The mental status is not likely to improve even after several minutes. Consider hypoglycemia in a patient who has altered mental status after an injury, such as a motor vehicle crash. Delirium is a symptom and not a disease. It presents as a new complaint. It's a temporary state that may have physical or mental causes, such as an infection, change in medication, or hypoxia, and it can be reversed with treatment. Signs and symptoms, rapid alteration between mental states, Sometimes it can mimic intoxication, drug abuse, or severe psychological disorders. Other causes of altered mental status, consideration of other possibilities becomes important because a patient with altered mental status may be combative or refuse treatment or transport. In most cases, a patient who appears intoxicated is, in fact, intoxicated. Psychological disorders and medication complications are also possible causes. Infections, particularly those involving the brain or bloodstream, may cause altered mental status as well. Seed safety is important, especially in your altered mental status patients, because again, they can have a wide range of signs or symptoms. They can have a wide range of responses based on what's going on in their brain. Don't be distracted by the seriousness of the situation or frighten family members. Consider the need for spinal immobilization in patients that have had a significant mechanism of injury. Look for clues to determine the nature of the illness, any special considerations for a patient with suspected neurological emergency, an evaluation of the environment for any signs of potential trauma. You're also looking for any medications in the area, any medications that the patient may be taking, indications of a previous medical condition, any evidence of a seizure, things are knocked over, a patient has oral trauma, there's incontinence. Also ask the family when the last time the patient appeared normal. In history taking, and investigate the chief complaint. For unresponsive patients, gather any history from family or bystanders or onlookers. Just ask somebody what happened. And also try to get the information from a couple of different viewers, because sometimes you have to put the pieces of the puzzle together by listening to the different stories. If no one is around, quickly look for explanations for the altered mental status, including stroke or seizure. Ask a responsive patient what happened, if they remember what happened. Evaluate a responsive patient's speech. When you're gathering a sample history, time is critical. Try to get the exact time the patient last appeared healthy. Collect or list all medications that you find in the environment or that the patient can remember they're taking if they are coherent. Ask if the patient has a history of seizures. Ask if this episode is different from previous episodes and what medication the patient takes. And if not, a serious condition should be suspected. There are a couple of different stroke assessments. We'll cover the very easy ones, and then depending on your area will depend on what type of stroke scale or stroke assessment they want you to do. Basically, we want to rapidly identify a stroke in the field so that they can go to a stroke center or receive stroke care or get the stroke team activated. Stroke scales evaluate the face, arms, and speech. There are 3 types that we generally discuss: Cincinnati Pre-Hospital Stroke Scale, Los Angeles Pre-Hospital Stroke Screening, and the three-item stroke severity scale, the LAG scale. And that looks at level of consciousness, arm drift, and gaze. The fast mnemonic covers most of them. We're looking at facial droop, arm drift, speech, and time. In facial droop, we want to ask the patient to show their teeth or smile. That's a good sign if they can do that. In the arm drift, we want to ask the patient to close their eyes and hold both arms out with palms up. If one is lower than the other, then that indicates that there is a droop or a drift. And then in speech, we ask the patient to say, "The sky is blue in Cincinnati." Both sides of the face move equally well. That's a normal response. If both arms move the same or neither arm moves, again, that is a normal response. And then if the patient's using the correct words with no slurring, "The sky is blue in Cincinnati," then that is a good indication that their speech is intact. Abnormal responses include one side of the face does not move as well as the other, one arm does not move or one arm drifts down compared with the other side, and the patient slurs the words, uses inappropriate words, or is unable to speak. So all of those would be an indication of an abnormal response, and any one of those is a consideration for a stroke that the patient needs to be evaluated. In the LA pre-hospital stroke screen, we're asking about age, if they have a history of seizures, how long the symptoms have lasted, at baseline, if they're not a wheelchair or bedridden, if their blood glucose is between 60 and 400, if there's obvious asymmetry, so the right versus the left, making sure both sides are the same in the following: the face, their grip, their ability to squeeze your hands with their hands, and their arm strength. And then the 3-item stroke severity scale, the lag scale, assesses level of consciousness for normal, mild dysfunction, severe dysfunction, arm drift for any normal, mild, or severe, and then gaze, which is normal, mild, or severe. Now notice that this one actually gives you a score. So if the patient scores more than 4 on this scale, then it very likely indicates that the patient is having a stroke. Even if it is less than a 4, the patient will still be evaluated for possible stroke. All patients with an altered mental status should also receive a Glasgow Coma Scale score, and the way that that is calculated is through the eye-opening, verbal response, and motor response. We also use the Glasgow Coma Scale for our trauma patients, our head injury assessments for our patients. So spontaneous is a 4. If the patient's eye opening is to voice, it's a 3. If their patient's eye opening is to pain, it is a 2. And if they do not have any eye opening, they're completely unconscious, that's a 1. And then their best verbal response, if you have a conversation with the patient and they appear oriented, they know person, place, and time, then they are considered oriented. They are confused if they don't remember person, place, especially time is questionable, depends on the circumstances or the environment the patient is found in. Inappropriate words, if they are not responding accordingly to what you're asking of them. And then incomprehensible sounds, that would be moaning, like that would be a 2. And if they have no verbal response, they're a 1. Your best motor response is if they obey commands, then that's great. So they get a 6. If they can localize pain, where does this hurt? They can point to it and show it to you. That's great. If they don't do that and you touch them in an area that hurts, or you are doing something like pinching their earlobe and they withdraw to pain, that's a 4. If they have abnormal flexion, which basically is that tonic maneuver, the patient's contracting the muscles. So you'll see the hands bending inward, you'll see the elbows flexed and bending inward. That is called abnormal flexion. And then abnormal extension is whenever the patient's muscles become rigid and straight. So the hands reach out, they hyperextend at the wrist, they straighten out and are tense, as well as the arms doing the same. And the patient, of course, is not responsive usually during this type of a situation. And that would be considered an abnormal extension. And if they have no motor response whatsoever, they get 1 point. So again, a rock is a GCS of 3. If a patient has a 13 to 15, then that indicates some mild dysfunction. Anything less than 13 is considered critical and needs to be evaluated quickly, depending on the situation. If it's a stroke, they need to go to a stroke center. If it is a trauma, then they need to go to a trauma center. A score of 8 or less is a significantly severe dysfunction. They need to be evaluated immediately. Emergency medical care for neurological emergencies may not always be clear. We do want to check blood sugars and fix that if we possibly can. ED physicians will determine if there's bleeding in the brain for patients with a suspected stroke. As soon as you go in, if they're suspecting the stroke and it's within a certain time window, then they will rush a CT scan. That CT scan gives them enough information that says there isn't anything obvious in there, so they're presenting like a stroke, but we don't see any bleeding, so that's good. Then we can consult with the neurologist. The neurologist can then determine if the patient is a good candidate for clot busting drugs. So using that clot dissolving medication can actually give hope to brain perfusion, and open up some of that brain perfusion again, or open up some of that brain circulation again. In patients that have a TIA, treatments are available if they're started right away. So there's a high potential for a patient to experience a major stroke within those 24 hours. So treating the patient's TIA, evaluating them for the causes of the TIA, that will definitely improve the outcome later on. In seizure patients, some of them will require definitive evaluation and treatment. Supplemental O2 is advised until they become perfused again. So, as if the patient is having a seizure and they're not breathing, then their skin signs are going to change. They're going to be labored respirations because they stopped breathing for a little bit. So, if you give them some supplemental O2 whenever they're done with the seizure, then you can increase or improve that oxygenation status, and then reevaluate. So as soon as their skin signs improve again and they regain their consciousness, reevaluate their oxygen saturation, and then you don't need to continue to provide oxygen at that point. If head or neck trauma is suspected, provide spinal immobilization. Protect them from harm is the biggest concern, and allowing them to go through the postictal state is also totally okay. For patients who continue to have a seizure, as in a status epilepticus, suction the airway if you can. If you can also provide positive pressure ventilations, if that's possible. Transport quickly to the hospital. Rendezvous with ALS if possible. Where you would provide those positive pressure ventilations would not be where they were continuously seizing. At some point, their body is going to become so hypoxic that the brain will shut off the motor component to the rest of the body and the seizing will stop. And then the brain goes through a process of reoxygenating. So it'll want to breathe heavily again. It's at that point that you provide the high flow oxygen positive pressure ventilations, because as the patient's brain starts to recover, it may re-enter into that seizing. And as it re-enters into that seizing, then the patient will stop breathing again. So we want to get as much oxygenation exchange as we can in the process between the two seizure episodes, or the three seizure episodes in a status epilepticus. For a headache, most headaches are harmless and don't require emergency medical care, but do be concerned if the patient is complaining of a sudden onset and very severe headache, or any sudden headache with fever, seizures, altered mental status, or following trauma. Those are high indicators for life-threatening headaches. In migraines, always assess the patient for other signs and symptoms that can indicate a more serious condition. Just because a patient has migraines does not mean that that is what they are experiencing now. In fact, they may be able to tell you that they feel the same as they normally do when a migraine comes on, or that this one feels different. If it feels different, for sure, they should be highly suspect for something going on besides a migraine. High flow O2, if it is tolerated and if they need that oxygenation, you want to look at, again, their oxygen status. A dark and quiet environment is the most comfortable for any patient that is experiencing a migraine. In emergency medical care for strokes, support airway, breathing, circulation, rapid transport to a stroke center. Use suction as needed to monitor the patient's oxygen saturation. They may require manual airway positioning. In certain strokes, they lose control over their ability to keep their airway open, usually because they lose control of the tongue. Maintain an SpO2 level of at least 94%. So you want to supplement. If their skin signs are bad, then you do high flow O2. If their skin signs are not bad and they're pink, warm, and dry, and you're checking their oxygen saturation and it's at 97%, then that is good. You do not need to provide oxygen for these patients. Oxygen therapy is not recommended unless the patient is in respiratory distress or it has obvious signs of hypoxia. Paralyzed extremities will require protection from harm. Make sure to keep those tucked in when you're moving the gurney around. Definitely keep the patient informed. And of course, under the right circumstances, the emergency room they go to may decide that thrombolytic therapy may reverse the stroke symptoms, and they can provide that. Try to spend as little time at scene as possible because stroke is an emergency. There is a time limit on when they can do those clot-busting drugs. So if possible, transport to a designated stroke center or follow your local protocol for the appropriate place to take patients. For seizures, the patient may be in a postictal state upon arrival. The patient may still be having a seizure. Continue to assess and treat airway, breathing, circulation, and try administering oxygen for that postictal hypoxic state. When the patient is actually physically having a seizure, it can be very difficult to place the patient in a gurney for transport. Try not to restrain a patient having a seizure if you can avoid that. Not every patient wants to be transported. In fact, if they have common seizures, if it's a normal part of their lives, then they may just have the seizure, and you wait for their postictal state to end and discuss it with them, and they'll decide not to go, as long as that's normal for them. If they're having increased seizure activity, more so than normal, if they're not taking their medications, or if the seizure is a status epilepticus, it goes on and on and on, then the patient does need to be transported and should be encouraged to be transported for additional evaluation. Altered mental status, that can vary from simple confusion to coma. And altered mental status is always an emergency that requires immediate attention. So we're going to do some of our sleuthing about the medical condition, see if we can figure it out, take as much of that information as we can find on scene to the emergency room to share with the doctor, and then maybe they'll be able to figure out the patient's altered mental status. Now in class, we'll be watching this video. Again, it's a great demonstration of what a TIA looks like and how it can be overlooked even by doctors and professionals. All right, we will see you on the next round.